My name is Ola Banjo, and I'm the Senior Director of Community Engagement and Partnerships at the Multiple Myeloma Research Foundation, also known as the MMRF. We are going to present some great information today. We really hope that it'll be impactful and really help you to be better advocates for your health. And, please feel free to gather all your questions. The other thing that I will say is throughout our presentation, you're going to see QR codes displayed on our screen. Feel free to go ahead and scan those QR codes whenever they come up so that you can engage with us. We've got some surveys in there. We've got just information about the MMRF. So thank you very much. So our mission at the MMRF is really just, highlighting where we are as the largest nonprofit organization dedicated to accelerating a cure for each and every multiple myeloma patient. We've driven the development of new, personalized, and innovative medications. But central to our mission is our commitment to health equity and making sure that every single multiple myeloma patient has access to care and is able to access those novel treatments that we're bringing into market. So in pursuit of our mission, the MMRF has focused our work around 3 pillars. So if you look up here, we've got our 3 pillars, first of which is accelerating the cure of accelerating the development of novel therapies, driving more optimal personalized treatment therapy, and also empowering patients in the myeloma community. Now, central to that mission is our commitment to diversity, equity, and inclusion, as well as belonging. So making sure, again, that every patient has access to the medications that we bring to market. We do want to accelerate a cure for each and every multiple myeloma patient. And our mission, and our vision rather, is a world free of multiple myeloma. So hopefully, we won't have to come back here and talk about multiple myeloma because there will be a cure.
All right, good afternoon, everyone. I think your first question is, what is multiple myeloma, right? Okay, so let's talk about that. It's a relatively rare blood cancer. It only affects less than 2% of the population, but it's the #1 blood cancer for Black Americans. It is a cancer that starts in the bone marrow, which is that spongy part inside your bones. The job of the bone marrow is to make all different types of blood cells, your red blood cells, your white blood cells, your platelets. And let's focus on the white blood cells for a second, because that's where myeloma really originates. There's a type of white blood cell called a plasma cell, and the job of a plasma cell is to produce antibodies when you encounter an infection. But what happens with myeloma is that the plasma cell has mutated. It's made one too many copies of itself. It's overcrowding that bone marrow and not allowing the bone marrow to do its job and not allowing your immune system to work at its full potential. So myeloma patients are easy to get infections, they have low blood counts, and it also damages other parts of the system, which we'll talk about as well. All right, so here are some crucial facts about multiple myeloma that everyone needs to know. As I said, it's rare, but it's actually the 2nd most common blood cancer overall, second only to non-Hodgkin's lymphoma. But again, like I said, it's the #1 blood cancer for Black Americans. So what do these statistics really mean? So the American Cancer Society estimated last year, there was about 35,000 new patients diagnosed with multiple myeloma, but 20% of those patients were Black Americans. And we also know that if we look at males versus females, males have a slightly increased risk of developing multiple myeloma. We also know that it happens to people who are a little bit older. So the average age of diagnosis overall is age 69. But when we actually tease it out by race, we see that Black Americans are diagnosed on average 4 to 5 years younger than white Americans. And we also have done a great job in improving survival rates for myeloma, as Ola was outlining. We have, due to new novel therapies that have been approved over the past several years, but we've not seen equal outcomes across the board. So we see improvements in survival rates for white Americans, but not for Black Americans as much. We still see that Black Americans are twice as likely to die of myeloma compared to white Americans. So it's very important for us to sort of understand this disparate statistic and sort of what we can do as a community to help bring that down. So I think people always, well, my patients always ask me, like, how did this happen? How did I get multiple myeloma? And so, we don't 100% understand how myeloma develops. We know there's some risk factors, but we also know there's some precursor conditions of developing active multiple myeloma. One of them is called MGUS, and that stands for monoclonal gammopathy of undetermined significance. So those patients are producing that sort of abnormal plasma cell I talked about in the bone marrow at a low level, that abnormal protein, that monoclonal protein, that strange immunoglobulin that they're producing at a low level, either in the blood or the urine. And it's not causing the body any trouble. So we just watch those patients to make sure everything's okay. Then we have what we call smoldering multiple myeloma, also known as asymptomatic multiple myeloma. Acronym SMM there for smoldering multiple myeloma. So those patients have a larger percentage of those abnormal plasma cells and those abnormal proteins in their blood and the urine. But again, it's not causing the body any sort of damage. So we watch those patients as well, but you can see the differences here. There is a risk of transforming to active myeloma. For MGUS, it's roughly 1% per year. But for smoldering myeloma, it's about 10% per year the first 5 years. And then it sort of gets less over time. So the longer you smolder, the less likely you're going to transform into active multiple myeloma. And right now, we don't treat these patients, we just watch them. But there's a lot of trials out there looking if maybe we can do something earlier instead of waiting for organ damage to happen. Particularly for our smoldering myeloma patients, there's clinical trials where you can maybe get ahead of before it transforms and actually bring down that level of the burden of the disease so that you can't even detect it anymore. All right, so we talked a little bit about what multiple myeloma is. Let's talk a little bit about what's happening in the body. So you can see that for those who have symptoms of multiple myeloma, you have a large amount of those abnormal plasma cells in your bone marrow, a lot of it in your blood or urine, and now it's causing the body troubles. So what do I mean by troubles in the body? We have an acronym called CRAB, and each letter stands for a clinical symptom that is happening to that myeloma patient. And if they have any one of those, they're diagnosed with active multiple myeloma. Let's start with the A, actually. So we talked about how the bone marrow is in charge of producing all your blood cells, particularly your red blood cells. And if the bone marrow can't do its job because you have myeloma, your red blood cells are low. And low red blood cells is called anemia, hence the A. And anemia can make you feel tired, it can make you feel short of breath sometimes as well. And then we can also see those myeloma proteins sort of gunk up the kidneys and cause problems with kidney dysfunction. And when we see that, we call that decreased renal function, renal for kidney. So that's the R. And then we can also see how those myeloma proteins can sort of upregulate cells in your body that break down your bones. So it can poke holes in the bones, it can make the bone brittle, easy for fracture. And so when there's bone damage, that's B for the CRAB criteria. And then that widespread bone destruction can cause the calcium to leach into the bloodstream. And high calcium levels are really toxic. They're toxic to the kidneys, makes you feel sick. So that's the C in the CRAB criteria. So a myeloma patient doesn't have to have all four. You just have to have one to be diagnosed with active multiple myeloma. We talked about a little bit about what's happening in the body. Let's talk about actually how that makes you feel. So we talked about the low blood counts, the anemia. That makes people feel tired, makes them feel weak. Red blood cells deliver oxygen throughout the body, so that can make you feel short of breath sometimes too when you're walking around. The effect on the kidneys can cause you to have less urine output, and even big problems with the kidney can make you have itchy skin and just feel unwell. And if there's a lot of proteins in the blood that the kidneys are trying to filter out, those abnormal proteins, it actually makes your urine look bubbly and foamy. So I've had a lot of patients tell me that they had sort of bubbly, foamy urine for quite a while before they were diagnosed with multiple myeloma. And then the bone damage. So the bone damage can make your bones hurt. The most common symptom of myeloma is anemia, But the most common physical symptom is that bone pain. Could be that back pain, rib pain, leg pain, that ache that's just not going away. And unfortunately, we can see patients see many providers before they're actually diagnosed with multiple myeloma. And then strangely enough, you can see 10 to 20% of patients have no symptoms at all. They just pick up the myeloma based on abnormal blood tests. All right.
At the MMRF, we believe in getting people on the right path so they can get to the right outcome. And what does that mean? When a patient is diagnosed with multiple myeloma, we try and encourage them to get to the right team. As Amy pointed out, it is a rare blood cancer, so not everybody is familiar with it. So we encourage patients to see a specialist in multiple myeloma, and there are out there, and we can help people find them. Once you do find a specialist, we do expect that you'll get the correct tests, but the right tests are very important from the very beginning, because the disease is something you will have long term. It's a lifetime thing. So a lot of the time, those tests from the beginning are going to be compared against as the years go by. And then the third part of this right path model that we have is the right treatment. And so the right treatment means the right treatment for that individual. There is not usually a one size fits all for multiple myeloma, because there are many subtypes. And depending on, as Amy pointed out, if you had kidney damage or other damage, they may have to adjust treatment based on that. So, but there are expectations for the standard of care that the physicians use for people with multiple myeloma. So when you get to the right team, and I think we covered this a little bit, when you get to a specialist center, there's not just the physician you'll see. There are other people involved in this care of a multiple myeloma patient. There's the clinical research nurse, there's the physician assistant, there's a social worker, and those are very important to help you access the support agencies and that you will need going forward. Back to the testing. So what would you expect to see when you have a diagnosis? So blood tests are going to be very much a part of what you will experience. They will do repeated blood tests to monitor initially what the disease looks like, but over time, how you're responding to the treatment. And they also use urine tests, because that protein can be excreted in the urine. So measuring that is important. Definitively, a bone marrow biopsy, which is a needle that goes inside the bone and samples that bone marrow, that is confirmatory for multiple myeloma, and it also gives us more information as to the subtype that we're dealing with. You'll also expect as a patient to see some imaging tests, so x-rays, CAT scans, and then there's a test called a PET scan, which is head to toe, to evaluate the skeleton of a person to see what kind of impact the disease has had, if any. The right treatment, that is a complex thing, but even though we know that this is an incurable condition, it doesn't mean it can't be treated. And it has phases of remission, and then you can see relapses as time passes as well. But there are treatments available. A specialist is needed, again, to explain the risks and benefits of each option to the person. And then we also encourage a patient to, for every condition, but to share with your team your preferences and your concerns and your family dynamics and your situation, so that you can work together to reach the best possible outcome for you. Again, it may look different for different people. And then we also encourage people to consider clinical trials. Clinical trials in a cancer patient will use standard of care. It will not use, you will not be able to treat it like a guinea pig. It is a standard of care approach, but they also are evaluating newer therapies to see, does that give us a better outcome for the patient going forward?
Thanks, Grace. Now that we shared sort of how to stay on the right track and advocate for yourself as a patient, I want to touch upon an inequity we've been seeing in our myeloma patients. So we talked about how Black patients are 2 times as likely to be diagnosed with multiple myeloma than white patients. We do see that CRAB criteria in all patients, but we see more of that kidney dysfunction, more of that anemia, more of that high calcium level in Black patients as well. But we also see a delayed diagnosis for our Black patients. Sometimes patients see a provider 3 or more times before they're actually diagnosed with multiple myeloma, which is not good, right? Suffering with that high calcium level, that anemia that's being untreated. We also see time and time again published reports, data showing that Black patients with myeloma are not getting therapy in a timely fashion. There's a delayed initiation to the time that they start therapy. They're less likely to receive a stem cell transplant, which is considered standard of care for newly diagnosed patients, and less likely to participate in clinical trials. However, studies have shown that if you treat Black patients in an equal access system and give them standard of care, they have the opportunity to achieve equal outcomes compared to white patients, sometimes even better outcomes. So what can we do to understand this a little bit better and advocate for ourselves? So now that you're really armed with this knowledge, I think the next question is, what can I do, right? There are no current guidelines right now for screening for multiple myeloma. So your primary care physician is not going to routinely look for this like they do for prostate cancer or heart disease. But there are various ways that you can assess your risk, including participating in clinical trials designed to understand the disease, how the disease develops and who really is at high risk. So for example, the PROMISE study. So this is the biggest myeloma screening study ever created, designed to prevent this blood cancer from occurring by catching it at an early stage. And to be eligible for this study, all you have to be is a Black American or any race with a first-degree relative with myeloma or MGUS or any of those other related conditions or any other blood cancer. It's amazing and I've been treating myeloma for a long time. It's amazing that studies like this now exist. And I know the MMRF has done incredible work in this arena as well to help the most vulnerable populations really achieve the best outcome. So we've given you a lot of information today. So let me give you a little bit of a summary. So myeloma is a rare blood cancer, right? But it's not rare for Black Americans. It affects the bones, the kidneys, the bone marrow. It weakens the immune system. It causes patients to have a high risk for infection. And despite these inequities in sort of incidence and outcomes and treatment amongst Black patients, evidence suggests that these disparities can really be overcome. And early screening can really help find cases of myeloma or precursor conditions. And so, we really invite you to scan this QR code here to take our post-program survey so that we can really continue to curate information that is useful and informative for everybody.
Thank you, Amy. Well, now we're going to hand it over to Ms. Lucretia Agee, our patient speaker, who's going to work us through her multiple myeloma journey.
Good afternoon. I'm glad they went through all the technical stuff so I can just get to my piece. Anyway, my name is Lucretia. I am a survivor, I'm a thriver, and I'm an overcomer. This year marks 14 years that I've been a survivor of multiple myeloma. Before I was diagnosed with myeloma, I wasn't really unfamiliar with the illness because in 2006, my oldest brother was diagnosed during a surgery for a knee transplant, and they found myeloma in him. And I'm happy to say that he has never had a relapse. And earlier this year, we celebrated his 79th birthday. So I'm grateful for that. I did learn quite a lot from him, but my journey with myeloma began in late 2008, and my life looked a very, very different picture. I was an active track and field coach, a single mother, and I had a full-time job. And I was running around the track one day, and my legs literally gave out from under me. I looked down and I had noticed that my legs, the skin on my legs, as skin on my other parts of my body, had turned completely black. I didn't know why. I didn't know what the issue was. Most of the discomfort that I felt was everywhere. It was just everywhere. So I couldn't really identify for my doctor. It's here, it's there. It was everywhere. And then I started bleeding 24/7. It was constant. So of course, anemia set in after that. And it was a very, very difficult time because I was still trying to raise a child and be a full-time worker as well. But it didn't stop me from doing any of that. I was in a lot of pain and it was difficult, but I was just as persistent as this illness was. And I just decided that I needed to find out what was going on, why this was happening. So I went to my doctor, my primary physician, who finally ordered an x-ray, a full body x-ray, which is where the myeloma showed up. It showed up as purple in my scans. My ribs were absolutely translucent. You could see through them as clearly as you could see through a window. My brain was covered with lesions and it looked like a block of Swiss cheese. It was a scary time. It was a very, very scary time. I think back to that time when I was finally correctly diagnosed because the first oncologist I went to told me that I had a gastrointestinal illness. And knowing just a little bit was just enough. I knew that wasn't right. So they put me in the hospital in a ward that I finally found out was a terminal ward. Yeah. And they left me there for 4 days, giving me fluids, and they finally did a bone marrow test, but no treatment. So I checked myself out of that hospital, went home, found my doctors. I found the doctors at Hackensack University Hospital in the John Thurber Cancer Center, who are specialists in multiple myeloma. And I've been with them now for 14 years. It's been an incredible journey, but you have to be your own advocate in any illness. You have to be able to research, study as much as possible, and find the best medical team able to handle what you're going through. What does my new normal look like? It doesn't look like a track coach. I was 52 years old when they told me, you probably won't see your next birthday. I'm 66 years old now. Yeah. And I'm grateful. I am very grateful. So what does my new normal look like? I stepped into a whole new reality after myeloma. I am a part of the African American Wellness Coalition. I sit on the boards of the Martin Luther King Observance Committee. I'm on the Community Health Day Observance Committee board. I am a part of the Community Oncology Board at Morristown Hospital, and I'm a 47-year member of Delta Sigma Theta Sorority Incorporated. And I still work full-time. Myeloma has not defined me. It is never going to define me. I go day to day, not unrealistic, knowing that there's no cure for this. There is no cure for this, but there is a way to fight back. And the way to fight back is to be as diligent and support your people, support your family, support the people that you are caregivers for, and get as much information out there as possible. We don't know what causes this illness, and it's one of the biggest and ugliest and scariest nemesis I have ever seen. But after all of these years, in these 14 years, I've had 2 transplants. The first one was a stem cell transplant in 2009. After that transplant, they said, oh, you'll have to come back in 3 months for the second transplant. I said, I don't think so. I'm tired. So I went home And I was cancer-free, well, basically in remission. You're never really cancer-free. But I was in what they called remission for nearly 4 years. In 2013, I had my first relapse. And I honestly think that that relapse was attributed to the death of my father. He passed that year. And immediately after coming back from his funeral in Mississippi, I got very sick, went to the doctors, and they found that my cancer had come back. So we went to a new regimen. It was including Velcade, dexamethasone, and that time we used a drug called Sotoxin. Sotoxin was a part of my medication. So I went through that. That was my second round of chemotherapy. After that, I went into another semi-remission. In 2018, it started showing up again. It had just transformed itself into this mass that settled into my sacral region. That's the butt, but y'all don't know what sacral region is. It was so painful that the only thing I could do was walk. I go to church, get up and walk. I would walk all hours of the night. I could not sit. I could not sleep. It was the most excruciating pain I have ever experienced. Even before diagnosis, the pain was bad. But when it decided to settle into a mass in that area, it became extremely scary. And my hope was starting to fade. But we decided to do radiation. That was my first round of radiation. I've had 2 of those. Then in 2019, we did another round of radiation because the lesion in my sacral region was not settling itself. It was not going away. The numbers were good, but it was not diminishing. So we did a second round of radiation. That radiation led to a second transplant, which was called the CAR T cell transplant, which is harvesting a patient's white blood cells. So that one was done in November of 2020. And here I am today on a new regimen because the results of the CAR T cell transplant were very, very good, but they didn't last as long as we had hoped. We thought that we would go at least a year on that. We thought we were going to ride that one for a little bit longer. In 10 months, I did not hesitate to call my doctor immediately when I felt the first twinge. And unfortunately, it was finding its way back. So now I'm in a clinical trial. Don't ever discount clinical trials. They can be a lifesaver. So that doctor who told me at the age of 52, oh, you won't see 53. I wish I could see her today. I really do. I've seen her only once since she said that to me. And to think that she sat in her office with a textbook on her lap, trying to figure out how to treat me. And I thank God every day for my own sense and my own fortitude to find caregivers and doctors, clinicians, and these lovely ladies from MMRL who are in the business of helping us to do better. But you have to be better yourself. You have to do better yourself. You have to stick to your regimen. You have to stick to a good diet. You have to exercise. And don't forget to meditate. Don't forget to thank God for what you have. Because we need to live in the day. And it's critical that we do all of those things collectively. You can't pick and choose because myeloma doesn't pick and choose. Myeloma hits anybody and everybody. So you can't pick and choose. You have to be strong enough to be better than myeloma. So this is my new look. This is my new look. And I choose to live right now in the strength that I have. That's the motto of our church for this year. Go in the strength that you have. I'm going in the strength that I have. And I'm giving it back as much as possible. So if there is something that inspires you, if there's something that encourages you to do something for someone else, go do it. Don't have a pity party. Go find something and watch yourself do better. And I'm not going to take up any more time because I know we're late, but I do want to thank you for your time. And I pray God's blessings on each of you. Thank you.
Thank you all for sitting through our presentation. You can find us outside in the exhibition hall. We've got a booth out there. Please come by and engage with us. We appreciate your time.